right, folks, it's the appointed hour. Welcome to the Health Informatics Seminar. I'm David Potenziani. I am serving as host today. Please remember that today's seminar is being recorded. Do mute your microphone while we're hearing the presentation. However, when we come to the Q&A segment, please feel free to unmute yourself, pose questions, make comments for our presenter to discuss. Alternatively, you may post in the chat where I'm happy to relay your question or comment. So let's begin. Professor Gurkhan, you are going to introduce our speaker.
Thank you so much. It's my pleasure to introduce our speaker today, Dr. Hao Lu, an associate staff scientist at Wake Forest University School of Medicine. Dr. Lu earned his PhD in electrical engineering from Rensselaer Polytechnic Institute, where he specialized in computer vision and machine learning. His research focuses on artificial intelligence and deep learning for medical imaging, with particular emphasis on automated disease diagnosis, multimodal data integration, and clinically deployable AI systems. Today's talk is titled An AI Assistant Supporting Middle Ear Disease Diagnosis from Otoscopic Videos. In this presentation, Hao will address a long-standing clinical challenge. Middle ear diseases such as otitis media are among the most common causes of hearing impairment worldwide, yet diagnosis via otoscopic examination remains heavily dependent on clinician experience. He will present an AI-assisted diagnostic system that analyzes otoscopic video to support detection and classification of middle ear pathologies using deep learning. He will discuss recent advances in multimodal AI integration and clinical validation, and will examine the broader challenges of translating AI technologies into real-world healthcare workflows. Please join me in welcoming Dr. Hao Lu.
Oh, hi. Thank you very much for introduce. I didn't do such a large presentation in front of so many people. I'm a little bit nervous, but I'm also very excited to share our result about the Otoscope project, which is the AI assistance system for doctors to do the otoscopy video diagnose. So in case I forget what I should present, I give an outline at the beginning. I will introduce the background vision at first, and then I will introduce our core technique and the multimodal breakthrough. Then I will introduce some of our current working, what we are trying to build a benchmark dataset for the otoscope video. And at the end, I will show a still demo. I'm sorry, I cannot run the real product of our work. And we are very welcome for everyone to come to our center and do a free otoscope exam. So let's start from the first part, the background and the vision of our project. So first, I want to give you some numbers. In shortly, more than half of the child under 10-year-old have at least one mid-ear disease. And for the primary care and children care, the doctor has only about 50% diagnose accuracy for the mid-ear diseases, compared with for very well trained experts ENTs. They usually have close to 75% diagnose accuracy. So this gap makes us, dive into this project. We want to develop an AI tool that can assist the primary care doctors to do a better diagnose. And when we really go into this project, we find the otoscope exam is very hard, especially for the young kids. When I organize my data set, I find one of the doctor write this line in their description. They said, the patient pushed me away during the exam. So then we notice our AI assistant system should not only have a very good accuracy diagnose for the patient, but also we should faster the review of the otoscopy exam, shorten the exam time so that we can make both doctor and the patient feel better. So the goal is to improve the diagnosis accuracy and reduce the time to do the decision. And the key challenge of our project is first, the data challenge. Currently, all of the public otoscopy data sets are very small. Usually have only 1,000 to 4,000 images compared to other data sets like ImageNet, which has more than 1 million images. And the second is most of those data sets come from only a single center, which make our algorithm hard to generalize to multi-center cases. And the second problem is the labeling challenge, because unlike the nature image tasks, they only need normal people to do the labeling. But in this case, we need well-educated experts, ENT experts, to do the diagnosis of the otoscope video. And sometimes they may disagree with each other. So for every video, we need multiple experts. And only when they agree with each other, we will settle down their diagnosis label. The third challenge is when we see the public data set, I, at least myself, feel like all the eardrum, exam can get a very clear, still solid eardrum image. But when I really see the, otoscope video from the primary care and the child care doctors, I find the video are usually blur, and sometimes there are sermons, and the video condition is very bad. And at the same time, the patient may have multiple diseases, and the stable, solid, and informative frame may only have 5 to 15 frames in the middle. So it is very hard for our algorithm to clearly select those informatic frame and do the very good uh, diagnose on that. So to deal with all these challenges, I will introduce our core method here, how we collect the videos and how we train the model, and how we deal with the generalizable problem. We actually use a multimodality method, and the performance increase close to 18%. So first, I will introduce the key frame selection. As I mentioned, the data collection is a very hard part, but thanks to our group, Dr. Gujen and Dr. Mobley, we have a lot of ENT experts to collect the otoscope videos from different centers. And currently, we have 2,347 otoscope videos from NCH, OSU, and VU. And all the otoscope videos have at least two ENT experts do the diagnose, and only the videos that both ENT experts agree with each other will left. So with all this solid data set, we can do our first task, which is the keyframe selection. As I mentioned, for an otoscope video, only very few frames have the only very free frame have excuse me. Only very few frame has the informatic information. So we need to develop an algorithm to find those frames. The first method is, of course, we want to train a deep learning model to automatically find those most informatic frames. So in this work, we select 146 videos because it is really hard to label all the videos. And we labeled more than 40,000 frames. The label contains 0, which means this frame doesn't contain the eardrum or cannot do the diagnose at all. And 1 means this frame has the eardrum and can do diagnose. 2 means this frame is very important. Only with this frame, the doctor can do the diagnose. So with this, we train a so-called auto-STVT method. The STVT method is a video summarization model. If you give them a video for the traditional STVT method, if you give them a video, and the output will be the keyframe that can reflect the video. And in our case, we not only find the keyframe to reflect the video, but those frames can contain the clinic information about the disease. So we add a new IDN network. This network is give the experts information to tell the model which frame contains the most important clinic information. By injecting this information, the STVT model can remove those frames that doesn't contain any clinic informations. So at the end, we get the F1 score close to 0.62, and the precision record result is 0.67 and 0.59. I know this number may not that exciting, but this is the state of the art for all the otoscope video keyframe selection. We do a lot of experience, compare our method with all the existing video summarization method, and this is the best. However, as I mentioned, the end-to-end trained deep learning model doesn't work that stable. But if we want to use it into the real clinic application, stable is the most important. We don't want to say, okay, for this patient, we can have a very good diagnosis. For another patient, it immediately become bad. And we rethink what caused the problem, and we find the main problem is we don't have enough label to label all the videos. As I mentioned, we only labeled 146 videos. It actually takes us more than 5 months. So in this case, we go step back, say, what about we use a kind of traditional method using the half knowledge based method. We not directly train an end-to-end model, but we label which frame contain we find which frame contains the eardrum and which frame contain which frame is blur or autofocus, and we also use a weakly supervised segmentation model which can detect the eardrum coverage. Say in this picture, the eardrum contain a very large part in the image to make sure the eardrum is not too small to see and hard to do the clinic diagnose. By combining all these three, small models, we can get a uniform informative score. And by ranking this score, we can select the top ranked frames. Say our model can only use these high informative frames, and then we can do a very good diagnose. And we use more than 2,000 videos to do the analysis. And in those 2,000 videos, we select 303 videos to do the evaluation, because these 300 videos have very good doctor diagnose and human labeling which frame is the best frame. Not all the frames was labeled, but at least we label which frame is the best frame for the doctors to do the diagnose. And by using this model, if we select the top 12 frames to do the automatically diagnose using a simple CNN model, the accuracy performance becomes to 77.5% accuracy, compared to only select the best frame from the expert. The expert select the best frame to do the diagnose, and that performance is only 0.3%. As I mentioned, a very well-trained ENT expert can only get about 75% accuracy. So our model is kind of comparable with a well-trained ENT expert in this case, currently in this stage. And we didn't stop there. With the keyframe, we are trying to improve the classification model. As I mentioned previously, we only use a simple CNN model to do the classification. And in this case, we are thinking, why don't we use a video model? Because CNN models still treat each frame independently. But if we use a video model, we treat all the frame together as a video, and we will use the temporal information. And the performance in the internal test is very good. By using a video VIT pre-trained by image network, by pre-trained by ImageNet, we can get 92% accuracy in internal case, which means all of the data come from the same center, which is OSU data. However, as I mentioned, we collect the data from 3 different centers. And for the external test, the accuracy immediately down to 68%. So this is, I don't know how to explain, but the generalized problem is there, because we find if we treat it as a video, the model not only remember the clinic information, but also how the doctor, turn around the camera and they remember the cover size of the otoscope and they remember the hobby of the doctor. So this makes the model overfitting to a certain center's data. So, and we are doing a research, review, and we find this is not only our problem. There are some reports claim that they find almost all of the current otoscope model met the same problem when they do the external test. The model accuracy vary from 34% to 70%. So we are thinking, how can we solve this problem? So first, we build a large data set from multi-center. The training data sets are collected by 3 different doctors and only from NCH center. And then the valid and test set is collected by a totally different doctor from a totally different center. By building this data set, we create a multimodality diagnosis model, which is not only use the otoscope video information, but also tympanometry data. The tympanometry exam is also a very common exam for the ENT doctors. They use this to test the pressure and recall frequency of the eardrum. So usually, if the doctor cannot tell the diseases very well from the otoscope, they will use the tympanometry to do the second round test. And we borrow this idea to our AI diagnose pipeline. We are thinking, why don't we totally mimic the human diagnose process? So by integrate this pipeline, of course, first, as I mentioned, we build a very solid data set first, and then we combine the video frames, the video information and the tympanometry information together to do a hybrid multiple diagnose. And here is the performance. If we only use the tympanometry data, the performance has only 54% accuracy because the tympanometry data cannot tell the tympanic sclerosis and the normal perforation tube very well. And as I mentioned, the otoscope video only has only about 65 to 68% accuracy. We report the lowest round here. But if we combine the otoscope and the tympanometry together, the hybrid model can increase up to 81% accuracy. This is because the otoscope video is hard to tell the effusion, AOM, and normal cases. However, these 3 cases can be separated very well in tympanometry data. The tympanometry is actually trying to detect whether there are effusion or other infection behind the eardrum. So by combining this together, the weakness solved by each other modality and the performance increase very well. So far, for all the researches, we find this is the best performance for the multi-center, with external test case. And with the for both the otoscope modality, tympanometry modality, and hybrid modality. And here is the detail of our model. You can see the blue is the sensitivity for only video, otoscope video. And the orange is a hybrid model with the otoscope video and tympanometry. You can see the sensitivity increase for all of the cases, especially for the ear effusion and the retraction. The retraction is the hardest part for the otoscope to see, because even though it's a video, but it's still very hard to reflect the 3D structure. But with the tympanometry data, we can test the pressure of the ear, so it makes the retraction becomes much easier to detect. Okay, this is the core breakout and the core technique of our current research we have already done. So here I will introduce some work we are currently doing. As I mentioned, currently all the public otoscope data sets are very small and only come from a single center. Since we already collect many videos from different centers, we want to organize this data set and build a standard benchmark for the otoscope video task and publish, so that it will help the following research to use this data set to improve this whole research area. What we want to do is currently we have as I mentioned, 2,347 videos. We will annotate them. Currently, we already have the ENT experts diagnose for all of the videos. And we want to further annotate them to label which frame contains the informatic clinic information. And we also want to label where is the eardrum, and for each frame, what disease it is. So here is an example of our labeling. The blue box is the bounding box of the eardrum, and we have a pixel level segmentation of the eardrum. And here is a hole in the middle of the eardrum, which indicate this is a perforation in this frame. And then for the video level, because perforation sometimes cannot see from the holes in the whole video. So for the video level, we have a video level diagnose. And then we will have the metadata integrate with this otoscope video, which contains the age, gender, and all other things. And after we label the whole data set, we will train the model for the object detection, which detect where is the eardrum, and do the semantic segmentation to segment the pixel level eardrum, and predict the frame level label, which frame is a key frame. Because as I mentioned previously, we already have this kind of tool. However, the end-to-end model doesn't work stable because we don't have enough data. Once we labeling all the data set, we can train a very solid end-to-end model and improve the keyframe selection performance even better. And at the end, we will do the video level understanding, which is the finally task about which can really use in the clinic to help the doctor do the diagnose. And this is the workflow we are currently doing. So I almost get the end of the presentation. This is an example of our product. We actually has already built a product with our model, which can in real time see whether you can see the eardrum of current frame and the quality of the frame you currently see. And we can do the diagnose in real time, say, okay, this patient has an AOM in this case. And if the patient has, if not the patient, if you cannot collect a high quality video, we will say, I'm sorry, the the current video is a low quality video. We cannot do a very good diagnose. And if you really want our algorithm to do the diagnose, this is circum the uh, uh, Cerament case is the eardrum is fully occluded by the ceramens. I'm sorry I cannot show a real-time demo in this presentation, but you all are welcome to come to our lab and we can give you a free eardrum exam. Okay, this is all my presentation. Do you have any questions?
I think it looks like in the chat, Deborah was wondering where the centers were, but I think you answered that. Deborah?
Yeah, later I saw you mention Vanderbilt and Ohio State, and I was just curious and think that it's not easy to model videos, and you've taught us a lot, Dr. Liu. But I was wondering, I guess it wasn't just North Carolina. You used centers in Ohio State and Tennessee. Others? How many centers?
Oh, NCH, which collect the children eardrums, and OSU and VU, they mostly collect the adults.
Thank you.
If
we'll
we
try
could,
to come to Wake Forest later. I appreciate the invitation.
So I'd like to go back for a moment to you were talking early about the data from one center, and then when you tried to expand the perspective to look at data from a second and subsequent center, it sounded as if the the accuracy of the results declined. And I was wondering, do you have an idea as to what were the characteristics between the first center that you evaluated and perhaps a second or subsequent one that you think contributed to that low quality of results?
Oh, thank you for asking. And I forgot to introduce in my presentation. We do a lot of tests there, and we find a lot of things can cause the difference. The most tricky one is color of the cover of the otoscope. When we do the otoscope exam, we don't want the otoscope camera, uh, touch the skin of the patient. So we will put a cover on that. And the size of the cover, the color of the cover is different from centers. And also the otoscope light, the brightness of the otoscope, and the camera series is different. Some centers use one, this brand's otoscope. Some others use another brand otoscope, and even this small, difference can cause the performance changes.
Okay. So you're working around some lack of some standard protocols in a way that a clinician wouldn't necessarily see as we have to adhere to this particular standard because they're not thinking about training an AI model. They're thinking about what is the patient in front of me and how are they presenting and, you know, what is the issue. Okay, so then I guess what you're trying to do is, I think, create this standardized approach that would leverage, yes, a very large amount of video data and other data into your model, but this doesn't look like it's being intended for specialists at a very high degree of training and experience, but rather clinicians who are doing these exams on a routine basis to be able to help them understand a problem. They may not really understand or be knowledgeable enough to diagnose what's in front of them. Is that a fair way to put it?
Actually, we want to build an automatically diagnose system to help all the doctors to do a faster, and easier diagnose. So we are still trying to test whether our system, how our system can help the trainees, new doctors, and very well trained doctors to do the diagnose. For the trainers, trainees, of course, they can benefit from our system. Our system can give a relatively reliable diagnose for them. But also, we think for the very well expert, uh, our model can make their diagnosis easier. They don't need to, focus all the time because our model can tell them this frame's quality is not that good. You need to, switch the angle of the otoscope and also give a reference diagnose for them in a very short time. And then I think it like an AI tool for, our normal life, right? For example, when I write an email, I can write an email very well, but if the AI can give me a template in a very short time, I can change a little bit word and make my work easier.
So let me ask about the implications of that. There's this sort of a two-part. First part, it sounds like you are intending for this approach to become a standard part of clinical practice for this area. And your hope is to be able to streamline and reduce cost of those people who practice.
Yes, yes.
Have you considered, when you reach that point, being able to see the possibilities of this approach being used in middle and low income country contexts to be able to bring a level of diagnostic sophistication and accuracy to places where they may not have that expertise?
Oh, that's a great idea. I should say, as a technique guy, I didn't think so much. But what we are trying to do is to make this as generable as much as what we can. So we hope this system can work stable in all situations. And of course, if this can help the low income country do a better diagnose, that will be great.
Okay. All right. Let's move to a different topic. And there's a question in the chat that apologies if I missed it, but what was the primary demographic of the people included in this study? And this person is also interested in the technical setup. Were there sensors or cameras how were they calibrated? And is there something, a lot of questions here. Is there something on the front end that will help indicate poor quality data while the examination is actually happening? So let's start with, who were the demography of the people included in this study? And I would add to that, were they what proportion were children, what proportion were adults, et cetera?
That's a great question. I don't have the number in my head immediately, but we do have the statistical analysis. Currently, for the children, we have around 763 videos around that. And for the for the adult, we have 1,005 or 600 around that. I cannot remember very well.
Okay.
And the children are, you know, the children is from 0 to 4 year old child. This is the definition of the children. Elder than 4 years old, I put them as an adult.
Okay.
And for the children, the gender is close to 47 to 53, around that number. I cannot remember which is the male and which is the female. I'm sorry. And the most common disease for the child is AOM effusion. And the most common disease for the adult is tube perforation and retraction. It is interesting. Seems like the infection always come from the child, the younger age. And yeah, close
Okay.
to this.
All right. So moving from the demography, how did you do anything to calibrate your sensors or cameras that were used, or did you just receive the data as was collected in a normal previous clinical encounter?
Yeah, we didn't calibrate it. We collect all kind of data. This is why we try, because in real clinic cases, doctors doesn't calibrate their camera, very frequently. So we want make sure our system can be generalized to all the centers. So we didn't do that.
I see. And so, and I'll just read this question as presented. Is there something on the front end that will help indicate poor quality data while the examination is happening? I presume the implication is perhaps you could prompt someone to provide better quality data if they understood they were doing something not perfectly.
Oh, yes, yes. This is one of our target, because this is not the original target, but during the research, we find most of the prime care and children care, they cannot do a very good diagnose. It's not because they don't have enough knowledge, but because they didn't collect the video very well. Their video quality is, sometimes too blur, sometimes too dark, and sometimes it's, only see a few parts of the eardrum, so that they didn't do the correct diagnose. And this is why we have a video quality in our interface, trying to tell the doctor, sorry, the current frame doesn't have a very good quality. You should change the angle of the otoscope or change the brightness. But currently, we only have this score to tell, the quality is high or low, but we still cannot tell the doctor what you should do to make the quality better.
Okay.
Maybe this will be our future work.
Okay. So one of the larger questions about AI and clinical diagnosis is getting clinicians to accept the validity of this tool. Have you presented any of these findings to clinicians? And if so, did they comment on the approach, particularly the multimodal diagnostic approach?
Not yet. This will be our next stage research. As you see, we have our product, and then we will send this product to medical student, doctors, ENTs, and to do the test, see how they feel about this.
Have you thought about doing that as a sort of a classic A/B test where you are able to look at traditional approaches and compare your approaches with an eye to, in the future, being able to show clinicians, here are the results of, the traditional human-centered clinical approach, and here are the results of our approach that does involve clinicians, but also uses AI.
Yes, yes, yes. This is work. This is the future work of our next stage. Yeah, we will record the diagnose accuracy and the diagnose time with and without the AI system.
And have you considered, and this is where we get a little bit into the weeds, have you considered being able to describe the model to clinicians? Because sometimes it's helpful for them to at least, they may not understand the machine learning aspects in great detail or much detail, but if they know there is this approach and they have uh, a sort of a top level understanding of it, they may feel more comfortable adopting this tool.
Oh, yes, that's a great idea. Actually, this is the first version. Currently, what we are trying to add is to add the probability of every condition. Say for AOM, we have maybe 90%, and 5% it can be a normal. And this is what we are trying to add. And also, we are trying to add at which area our model are focusing on to do the diagnose. For example, here our model may focus on the flat the this eardrum,
Mhm.
this kind of area. We are doing that. That's a great idea.
Um, so, have you considered in the future being able to go to some of the standard settings organizations among ENTs and the like to be able to say, when you have improved this tool and you're ready to present it more fully to the clinical population, to be able to say, we would love for people to say this is a officially approved approach for diagnostic procedures for this particular set of issues. Have you thought about going to the, whether they be the licensing or professional organizations to be able to get their buy-in to this?
I didn't think about that yet. I think that the next after the next step, maybe we can think. But currently, I'm still focused on the technique part.
Okay. So just my final question is, so what is your next step? What do you envision doing next?
So the next is first, we will build a benchmark of the data set, as I mentioned,
Hmm.
and then we will test our product with the medical student, new doctors, and ENT expert to see how well our model have their work. So we are doing this two branch together at the same time.
Excellent. All right. Well, we thank you very much for making a very interesting presentation and showing at least this type of AI may be helpful in the future to standardize and improve diagnostic techniques.
Thank you. Thank you very much.
All right. We will see as many of you as would like to next week. Thank you.
Bye bye.